Assalamu alaikum, dear students. This is the lecture of gross anatomy for first professional MBBS students. Today we will discuss the major branches of the brachial plexus and their clinical relevance. I am Dr. Karimullah, Demonstrator Anatomy Department, GKMC Swabi. The major branches of brachial plexus. These are the musculocutaneous nerve, the axillary nerve, the median nerve, the ulnar nerve, and the radial nerve. First of all, we take the musculocutaneous nerve. Its root value is C5 and C6. That is, it is formed by the interior primary rami of the C5 and C6. It is the continuation of the lateral cord of the brachial plexus. Its motor supply is to the biceps brachii, the brachialis, the coracobrachialis. Its sensory supply is to the lateral aspect of the forearm by means of the lateral cutaneous nerve of the forearm. Its injury is very uncommon, but if it occurs, it can be due to a stab wound in the axilla. The effects of injury will be upon the BBC, the brachialis, the biceps, and the coracobrachialis. These are paralyzed. The axillary nerve, its spinal root is C5 to C6. Its anatomical course is it is the continuation of posterior cord of the brachial plexus. It exits via the quadrangular space of the shoulder along with the posterior humeral circumflex artery. The branches are motor and sensory. Motor are for the deltoid and teres minor, and the sensory branch is the upper lateral cutaneous nerve of the arm, which is the continuation of the posterior terminal branch of the axillary nerve, which is to the skin over the deltoid region. And this region is called the regimental beige area. A third branch it gives to the shoulder joint. The regimental beige area is divided into 4 quadrants, and an intramuscular injection can be given in the upper lateral quadrant 1 to 2 inches below the acromion process. Damage to the axillary nerve. The causes of damage may be anterior dislocation of the glenohumeral joint or the shoulder joint, the fracture at the surgical neck of the humerus, the misuse of the crutches, carrying heavy backpacks, blunt trauma to the deltoid, and the quadrangular space syndrome, or the iatrogenic due to the use of drugs or due to some illnesses. The clinical features are wasting of muscles and impaired sensation over the deltoid region. The median nerve, its root value is C5 to T1 spinal segments. It is derived from medial and lateral cords of the brachial plexus. The motor function is it supplies the flexors of the forearm, the theners, and lateral 2 lumbricals of the hand. Except the flexor carpi ulnaris and half of the flexor digitorum profundus, which is supplied by the ulnar nerve. The sensory function of the median nerve. The palmar cutaneous branch. The palmar cutaneous branch arises in the distal forearm and passes above the flexor retinaculum, enters the palm, and supplies the lateral aspect of the palmar region. The digital cutaneous branch supplies the lateral 3.5 digits of the hand. The median nerve enters in the carpal tunnel and gives within the hand 2 branches. The recurrent branch, which supplies the thinner muscles, and the palmar digital branch, which supplies the palm and fingertips, and lateral 3.5 digits and lateral 2 lumbricals. The clinical relevance of the median nerve. The carpal tunnel syndrome. The cause may be thickened ligaments and tendon sheaths, and or may be idiopathic. Idiopathic means unknown cause. If the condition is left untreated, it may lead to weakness and atrophy of the thinner muscles as shown in the diagram on the right side. The sensory complaints may be numbness, tingling, pain in the distribution of the nerve as shown in the palm of the hand on the right side, and the pain may radiate to forearm, wake up the patient at night, and may be worse in the morning. The condition can be confirmed by two types of tests: the positive Tinel's test and the positive phalanx maneuver or the positive phalanx test. The Tinel's test we use to strike over the flexor retinaculum in order to elicit or trigger pain in the distribution of the compressed median nerve. And in the phalanx maneuver, we used to flex the hand, the suspected hand, at 90 angle for 30 to 60 seconds, and the pain is elicited in the distribution of the median nerve, and we confirm the carpal tunnel syndrome by this particular method. The median nerve damage at the elbow results due to supracondylar fracture of the humerus bone, and the presentation is constant supination of the forearm, weakness of the flexion, which is accompanied by abduction due to pull of flexor carpi ulnaris. The thumb is prevented from flexion due to paralysis of the flexor pollicis longus and flexor pollicis brevis muscles. Lateral two lumbricals are paralyzed, leading to loss of flexion at the metacarpophalangeal and extension at the interphalangeal joints of the index and the middle fingers. The sensory functions are the loss of medial nerve sensations, as we discussed in the carpal tunnel syndrome. The characteristic sign of the hand will be there will be wasted thinner eminence, and if we ask the patient will be able only to flex the little and ring fingers completely on making fist. The radial nerve, its root value is C5 to T1 spinal segments. Its anatomical course is it is the continuation of posterior cord of the brachial plexus. It lies posterior to the brachial artery in the axilla. In the arm, it supplies the long and the medial head of the triceps. The short head of the triceps receives a branch given by the radial nerve in the axilla. Then the radial nerve passes in the radial groove and the humerus bone along with the brachial artery. Over the lateral epicondyle of the humerus, it divides into deep branch, which is motor, and the deep branch then becomes the posterior antroicious artery and the superficial branch. The superficial branch is sensory, and it supplies sensations to the hand and the finger on the dorsum of the hand. The sensory functions of the radial nerve. The radial nerve gives four cutaneous branches. The lower lateral cutaneous nerve of the arm, as shown in the diagram by green color. The lateral arm below the deltoid is supplied by this nerve. Number 2. The posterior cutaneous nerve of the arm, it supplies the posterior surface of the upper arm, shown by the sky blue color. The third, the posterior cutaneous nerve of the forearm. supplies the middle of the posterior forearm shown by the yellow color in the forearm. Number 4, the superficial branch of the radial nerve. It supplies the dorsal surface of the lateral 3.5 digits and their associated area is shown by the red color in the hand and the distal forearm. The clinical relevance. The radial nerve can get damage in 4 places. Number 1, in the axilla. The cause may be the posterior dislocation of the shoulder joint or the badly fitting crutches, which can result in posterior dislocation. The clinical sign will be loss of extension and there will be a drop of the hand at the wrist. And this wrist drop is due to the unopposed flexors of the hand, which pulls the hand towards flexion. The sensory loss. Sensation is lost over the lateral and posterior upper arm, posterior forearm, the dorsal surface of the lateral 3.5 digits. All these are shown in the diagram on the right side and the below diagram. Injury to the radial nerve in the radial groove. The cause is fracture of the humeral shaft. The motor effects are the weakness of the triceps. The triceps are weakened but not paralyzed. Why? Because the short head of the triceps receives nerve supply from the radial nerve when it is passing in the axilla, so it is spared. And the triceps is not paralyzed but only weakened. The deep branch is affected. It is the posterior compartment which loses its function, and all the posterior compartment muscles, that is the extensor muscles, are paralyzed, and there is wrist drop and the finger extension is not possible. The sensory effects are the same as those in the nerve injury in the axilla. All the 4 sensory nerves are affected. Injury to deep branch of the radial nerve. The cause is fracture of the radial head or dislocation. The motor effects. All the extensors are paralyzed and the ECRL is spared because the ECRL, or the extensor carpi radialis longus muscle, receives its motor supply from the radial nerve right above in the arm. Thereby it prevents the wrist to drop. There is no sensory loss because it gives no sensory branch. Number 4, the injury to superficial branch of the radial nerve. Superficial branch of the radial nerve, the cause is stabbing or laceration wound of the forearm. The motor effects are none because it is purely sensory. The sensory effects are sensation loss over the distal surface of the lateral 3.5 digits and the associated palmar area. The ulnar nerve. Its spinal roots are C8 and T1. The anatomical course of the ulnar nerve. It is the continuation of the medial cord. In the arm, it lies on the medial side. At the elbow, it lies posterior to medial epicondyle and is superficial and can be palpated or it is palpable against the bone. In the forearm, it pierces the flexor carpi ulnaris and pass along the ulna. The motor functions are, it supplies the flexor carpi ulnaris and medial half of the flexor digitorum profundus in the forearm, except thinner and lateral 2 lumbricals and medial half of the flexor digitorum profundus. It supplies all the muscles of the hand. In the thinner, it supplies the its deep branch supplies the adductor pollicis muscle. The sensory function, it supplies the anterior and posterior surface of the medial 1.5 fingers and the associated area of the palm. Branches of the ulnar nerve. Motor branches in the interior compartment of the forearm, the flexor carpi ulnaris and medial half of the flexor digitorum profundus it supplies. The palmar cutaneous branch, skin of the medial half of the palm is supplied by the palmar cutaneous branch. The dorsal cutaneous branch, a medial 1.5 fingers and the associated palmar area is supplied by the dorsal cutaneous branch. At the wrist, it passes over the flexor retinaculum in Guyon's canal along with the ulnar artery and gives superficial and deep branches. Now, in a nutshell, all the functions. In the forearm, the flexor carpi ulnaris and flexor digitorum profundus medial half is supplied by the ulnar. In the hand, the deep branch gives supply to hypotenuse, all the hypotenuse, medial two lumbricals, and the adductor pollicis, which is the member of the thinner muscles, and all the interossei, whether the dorsal or the palmar interossei. All these are supplied by the ulnar nerve. Sorry. The sensory nerves. The sensory are three nerves. Two arise in the forearm and one in the hand. The palmar cutaneous branch. It is shown by yellow color in the diagram, and it supplies the skin on the medial half of the palm. The dorsal cutaneous branch, it is shown by the green color, and it supplies the skin of the medial 1.5 of the fingers and associated palmar area. The superficial branch, it arises in the hand, the palmar surface of the medial half of the 1.5 of the finger it supplies. Injuries of the ulnar nerve. The ulnar nerve is most susceptible to injury at the elbow and the wrist. At the elbow, due to fracture of medial epicondyle, the ulnar nerve can be damaged. The effects will be motor function of the FCU and medial half of the FTP and the interossei are lost. So there will be loss of adduction and abduction of the fingers, which is the function of the interossei, and there will be a guttering between the metacarpal bones because the interossei are present in between the metacarpal bones. The paralysis of medial two lumbricals results in reduction of tone in little and ring fingers. The characteristic sign: the patient cannot grip paper placed between these two fingers because there is loss of tone or power. The sensation: all sensory nerves are affected. Ulnar nerve damage at the wrist. The cause is laceration. The motor effects are the same as those for injury at the elbow, but the FCU and FDP are spared. The sensory functions: palmar and superficial branches are usually injured. The dorsal branch remains unaffected, and there is a sensory loss over the palmar side of the 1.5 fingers. The ulnar claw, it develops in long-standing cases. It consists of hyperextension of the metacarpophalangeal joints of little and ring fingers. This is because of paralysis of the medial two lumbricals and the now unopposed action of the extensor muscles. If the lesion occurs close to the elbow, this might not be evident as if the P will be paralyzed. Thank you, students. In the last, I may give you a message that the brachial plexus is very much important regarding the knowledge of the upper limb. Regarding the knowledge of the upper limb, I may simply say that if a person has a gun but having no bullets, the gun is of no use. If you have the knowledge or full knowledge of upper limb but you don't know anything about the brachial plexus and its branches and its clinical relevances, your knowledge is of no use. So please remember me in your prayers. I will remember you in my prayers. Thank you very much. Wish you best of luck. Thank you.